Hi everybody, it's really nice to see so many of us on the call today. My name's Jaspreet, I'm the Chief Pharmacist at Bradford District Care Trust, which is a mental health and community trust in West Yorkshire. Really pleased to be able to introduce the webinar today, which is going to focus on pharmacogenomics with a specific focus on mental health. We've designed this for the North Eastern Yorkshire Genomic Medicine Service, and this is Emma and Adam's work, who I'll introduce in a minute. We've specifically kept it to 30 minutes, so it's like a bite-sized session. Appreciate all the pressures that everybody's under, especially with the junior doctor strike this week, so hopefully you're not all tearing your hair out with that. So yeah, next slide, please, Emma. The session's being recorded as well, as Emma said, just so you're aware. So just a few housekeeping points. If you can make sure you stay on mute, please, that'd be really helpful, just so that we can get through without any interruptions. We should have time for questions at the end. So if you want to ask a question at the end, please raise your hand. I'm not sure if people have access to the chat, Emma, if that would be an easier way. Is that possible, or?
We may be able to activate it at the end of the webinar.
Brilliant. Okay, fabulous. And like I said, we've said before, it will be recorded, so anybody who's missed it today should be able to access it. Hopefully you all know how to use Teams, but there's just a little bit of an instruction there. And like I said, it'd be really helpful if you could send feedback if you found the session useful, or if there's anything you'd like to cover in future sessions, that would be really great. So yeah, next slide. So to introduce our speakers today, so we've got Emma Groves, who is the NHS North East and Yorkshire Genomic Medicine Service Alliance Pharmacy Lead. That's not a mouthful at all. Emma and Adam have kindly put this session today. So Emma has done further education in genomic medicine at Newcastle University, and I've heard her speak a few times on this topic, so I think you'll all find this session really useful. And then Adam Jameson, who is a clinical pharmacist here where I work at Bradford District Care Trust, and he's also completing a PhD in this topic with the University of Bradford. So thank you both very much for putting all of this together. It's very, very helpful. And so, yeah, just a quick agenda. I've done welcome and introduction, so you won't be hearing from me again. Emma is going to walk us through an introduction to pharmacogenomics, so sort of 5 minutes on that. And then Adam is going to focus a bit more on its application in mental health and a bit more about the research he's doing. And then hopefully, if we have time, we should have time for questions at the end. So over to you, Emma.
Thank you. So I'm going to kick off with Pharmacogenomics 101. As we said, we have 5 minutes to cover this agenda item, so I'll not be able to cover everything in depth, but I will signpost to some useful resources afterwards. So the definition of pharmacogenomics, which is often used interchangeably with pharmacogenetics, and it refers to the study of how a person's genetic makeup affects their response, both in terms of efficacy and/or safety to a drug. And it can be very useful in helping clinicians decide what medication to prescribe a patient and at what dosage, informing that shared decision making. So, variation in drug response. As healthcare professionals, we all know that there's variation in drug response, and when the same medicine is given to different people, you see a spectrum of efficacy and toxicity. And why this is important is because although medicines are the most common therapeutic intervention in healthcare, what the literature shows is that only 30 to 50% of medicines are effective. And what's more is 1 in 15 hospital admissions are linked to an adverse drug reaction. So, if we can make improvements in the efficacy and safety of medication, taking into account genomic information, then this will have significant benefits to patients, and there's also potential for cost saving to the NHS. So, although we're advocating for thinking about integrating genomic information into shared decision making, it's important to remember that variation in drug response is due to a variety of factors, which are listed on the screen. So, things like multiple health conditions, genomic variation, demographics, environment, drug and food interactions, drug drug interactions, renal and hepatic impairment, and adherence. So, genomics is just another piece of the puzzle. So now I'm just going to take you back a little bit to pharmacology. So this image is taken from a recent British Pharmacological Society report on precision medicine, which is really good if you want to have a look at that. And the image illustrates that when you take a medicine, there's both pharmacokinetic and a pharmacodynamic process. So, as we know, pharmacokinetics is what the body does to a drug. So, that's absorption, distribution, metabolism, and excretion. And pharmacodynamics is what the drug does to the body. And a drug molecule can have an on target and an off target effect. And the important take home message here is essentially every time a medication is interacting with the body, it's interacting with a protein. And that's where pharmacogenomics comes in, because that protein is coded for by our DNA, and these proteins are often enzymes. And what we know is that common genetic variation can impact how these proteins work. So, over the last decade, there has been significant evidence built up about how genetics can inform prescribing of many common medicines. And the FDA actually have a list of 517 drug gene pairs, which are included in their drug labels. And of those, there's 26 gene drug pairs which have explicit pharmacogenomic guidelines. And these guidelines are written by an American group called the Clinical Pharmacogenetics Implementation Consortium. And what's more is that it's estimated that approximately 98%, so that's pretty much everyone in the population, carry at least one actionable pharmacogenomic variant. However, despite all this, implementation of pharmacogenomics in the NHS has been quite limited. And I've put a little picture on there of common drug gene pairs which are used in clinical practice. And the approach that is taken for implementing testing is very much a reactive approach. So, what you'll find is that a patient would attend a specialist clinic and be consented for a genetic pharmacogenomic test, and then that would then inform the prescription. But it's recognised that going forward, this approach is not necessarily cost effective, and it might be more useful to do an upfront test of lots of drug gene pairs. So that's really what we're thinking of in the future. So this diagram illustrates what the future could look like. So on the left-hand side of the screen of the diagram, we have different individuals who are all prescribed the same medicine. And the standard approach is that they would be prescribed a drug based on that very much one size fits all. And that might be based on clinical guidelines, renal or hepatic impairment, weight-based dosing. But what then happens is that the patient's response to that medicine will differ depending on their genetic makeup and the other factors that we discussed. And then there's that kind of trial and error where a medication might need to be up titrated or dose reduced or medication stopped if a patient had an adverse drug reaction. Whereas what we're really thinking about on the right-hand side and what the future may look like is what we call a pharmacogenomic approach, where you could do a test upfront, and that would probably be for multiple genes all at once, what we call a pharmacogenomics gene panel. And then that information would be analyzed in the lab, and then the results stored in the patient record. And it would only need to be done once as well, because a patient's germline DNA does not change throughout their lifetime. So whenever a prescriber came to prescribe a medicine, then rather than that trial and error approach on the left, you could use that pharmacogenomic information to tailor the drug dose and choice first time. So if you want to know more about pharmacogenomics and core concepts, I've popped in the chat a link to the pharmacy webpage for the Northeastern Yorkshire GMSA, and on there's a whole host of education resources that are definitely worth a look. So now I'm going to hand you over to Adam and think about how we can bridge that translational gap. So as I said there's a lot of evidence out there around pharmacogenomics, but there's a bit of a gap in terms of implementation. So I'll hand you over to Adam.
Brilliant, thank you for that, Emma. So my name's Adam. I'm a clinical pharmacist at Bradford District Care Trust, and I'm also a PhD student at the University of Bradford as well. And today I'm hoping to talk a little bit about pharmacogenomics in mental health. I've got a long list of supervisors, some of them internal at the University of Bradford, and also Jaspreet is my clinical supervisor based at Bradford District Care Trust. So yeah, as I mentioned, today I'm going to talk a little bit about the potential for pharmacogenomics to be applied, particularly in relation to helping to prescribe psychotropic medications. And then I'm going to talk a little bit about some of the research that we've done, exploring the barriers and enablers to implementing pharmacogenomics in mental health settings. So why is pharmacogenomics important in mental health? So as Emma mentioned a couple of minutes ago, the FDA have got a long list of drug gene pairs, and around about a third of them relate to psychotropic medications. And some of them you can see on the right hand side. So they're mainly antipsychotics and antidepressants, and they mainly center on gene variants for cytochrome P450 enzymes such as CYP2D6, CYP2C19 and CYP2C9. In psychiatry, when we're prescribing medications, we're kind of presented with many challenges. We have high rates of adverse drug reactions, low rates of therapeutic response, which contributes to medication non-adherence. And overall, we've got a kind of trial and error approach to prescribing antidepressants and antipsychotics. And we know that in part that this can be some of the kind of variation in response to medications used in mental health can be explained by pharmacogenomics and a patient's kind of genetic profile. So in terms of psychiatric pharmacogenomics, the focus is more on genetic variants that influence pharmacokinetic processes. That's not to say that research isn't ongoing looking at pharmacodynamic pharmacogenomics, but at present there's more evidence, there's more of a evidence base for pharmacokinetic pharmacogenomics. So with that said, most psychotropics medications are metabolized by either CYP2D6 or CYP2C19. That's just a bit of a general rule, but in general, to some extent, most medicines used in mental health are metabolized by either CYP2D6 or CYP2C19. And we know that when patients have a genetic variant for one of these genes, this can lead to an altered phenotype and change in the function of these enzymes, which can lead to differences in the way patients respond to medications. If you just want to click, Emma, it'll just bring a couple of images up. There we go. So what does this mean for patients? There are different metabolizer types for these cytochrome P450 enzymes, and on the kind of image that you can see on the screen, the metabolizer type can range from an ultra rapid metabolizer all the way through to a poor metabolizer. So if you take a patient who's taking a medication that's primarily metabolized by CYP2D6, if they're an ultra rapid metabolizer, this means that they're going to break down and metabolize the drug more quickly, which will lead to reduced plasma levels of the drug, as seen in the kind of person in the top left. And then on the other end of the spectrum, you have patients who are poor metabolizers. So this will mean that they break down and metabolize the drug more slowly, which will lead to increased drug plasma levels of the drug. And the impact of this is that for the poor metabolizers, they're more at risk of experiencing adverse drug reactions because they've got higher plasma drug levels. And then for the ultra rapid metabolizers, they're at a higher risk of not responding to the medication because they've got lower plasma levels of the drug. So focusing on some of the drug classes that we use in mental health, firstly, we'll start off with antidepressants and have a look at the evidence for antidepressant pharmacogenomics. There's been 2 systematic reviews and meta-analyses conducted within the last year or so that have basically aimed to assess the impact of using pharmacogenomic prescribing approaches on antidepressant outcomes. And both of these systematic reviews and meta-analyses have found that the likelihood of symptom improvement or symptom remission is improved following the use of pharmacogenomics compared to kind of standard treatments. And this backs up the evidence that was found in earlier systematic reviews. So there's just another, there we go. So in terms of overall what we know about using pharmacogenomics to help guide antidepressant prescribing, we know that it can increase the likelihood of treatment response and remission. Many of the populations that were in the studies included in these systematic reviews looked at the use of pharmacogenomics to help prescribe antidepressants in patients that have had previous treatment resistance and also multiple depressive episodes. So we need more research and more studies exploring the role of pharmacogenomics in preemptive pharmacogenetic testing, which is kind of prescribing, looking at using pharmacogenetic testing prior to the prescribing of the initial antidepressant compared to many of the studies that have looked at using pharmacogenomics when patients have already been trialed on a number of antidepressants. We know that we need to look at more diverse populations in these studies. We know that Black and ethnic minority groups are significantly underrepresented in the studies that were included in these systematic reviews. And we need to also explore the real-life application of pharmacogenomics in healthcare systems such as the NHS. So that was kind of antidepressant pharmacogenomics. Now looking at antipsychotic pharmacogenomics, the field's a little bit further behind. There's not as stronger evidence base for using pharmacogenomics with antipsychotics, but that's just because the studies are kind of still ongoing a little bit with looking at the outcomes from using pharmacogenomics when we're prescribing antipsychotics. But having said that, there was a systematic review published in 2021 that found that CYP2D6 poor metabolizers were more likely to have higher plasma levels of aripiprazole, risperidone, and haloperidol compared with normal metabolizers, which kind of provides a bit of a rationale for exploring CYP2D6 genotype when we're prescribing these antipsychotics. So CPIC, that's the American organization that produced guidance on pharmacogenomics. They've produced guidance for aripiprazole, risperidone, haloperidol, and zucopentixol, and their clinical recommendations are basically that for poor metabolizers of CYP2D6 that they should have a reduced dose of these antipsychotics. So all of this evidence has led us to the production of the first set of guidelines for using pharmacogenomics in psychiatry. This was published in 2021, and the kind of take-home message from this is that when patients have experienced side effects or inefficacy when they've been prescribed antidepressants or antipsychotics, that at that point we could then consider offering a pharmacogenetic test to see if there's a genetic explanation for why they may have experienced side effects or a lack of therapeutic response. So for SSRIs and SNRIs, they advise that especially when trialed SSRIs or SNRIs have got similar metabolism routes, we should be considering the use of pharmacogenomics. And then for antipsychotics, it's similar when the trialed antipsychotics that a patient's had, if they've got similar metabolism routes, i.e. that they're both primarily metabolized by CYP2D6, we can then look at offering a pharmacogenetic test to see if the side effects or inefficacy may have been in part due to the patient's genetic profile. So that's a bit of background about pharmacogenomics in mental health. So now moving on a little bit to kind of the research that we're carrying out. This is a mini review that was published in 2021, where we basically looked at some of the barriers and enablers to implementing pharmacogenetic testing in mental health care settings. So this was like the first piece of work that I did as part of my PhD. So why did we want to do this review? We found that there was limited implementation of pharmacogenomics in mental health settings. In the NHS, it is virtually kind of non-existent, the use of pharmacogenomics in mental health settings. And this is despite the growing evidence supporting the use of pharmacogenomics that we've kind of discussed in previous slides. We know that there are challenges to prescribing medicines in psychiatry, and that pharmacogenomics can help to address some of these. So how did we conduct the mini review? We performed a literature search on 3 databases. We used keywords such as pharmacogenomics, pharmacogenetic testing, mental health, psychiatry, and in the end we were left with, we found 11 papers that were suitable for inclusion. And we used thematic analysis to synthesize the key barriers and enablers to implementing pharmacogenomics in mental health settings. So on the next slide, I think we're going to look at the enablers first. So here's a list of the key enablers that we synthesized from the included studies. So in general, we found that there was a perception that pharmacogenomics can lead to precision prescribing. There was a general interest from both healthcare professionals and patients in the use of pharmacogenomics. Healthcare professionals felt that the use of pharmacogenetic testing could help to aid the clinician-patient relationship, which is something that's really important in the field of psychiatry. Both healthcare professionals and patients felt that pharmacogenomics would become more routine in the future, and then it could help to reduce adverse drug reactions and guide prescribing decisions. So moving on to the barriers that we found. As with many interventions in healthcare, we found that cost and funding was a kind of barrier to implement in pharmacogenomics. We also found that kind of practitioners were citing a lack of knowledge about pharmacogenomics and its current evidence base within mental health. Staff were concerned about they kind of reported issues around how they would incorporate pharmacogenomic testing into current workflows and how they would embed pharmacogenetic testing into existing clinical pathways. There was also a reported risk of misinterpreting the results, and there was one included study also cited a lack of clear guidance around the use of pharmacogenomics in psychiatry. But obviously now we've got the guidelines around using pharmacogenomics in mental health that actually kind of address that barrier a little bit. And there was also concerns from healthcare professionals that pharmacogenomics may end up replacing clinical judgment in the future. So that was the kind of mini review that we did early on in my PhD. So in terms of what we've got planned in the remainder, we are conducting a systematic review that's exploring the barriers and facilitators to implementing pharmacogenomics in mental health. So very similar to the mini review, except this time we'll be taking a bit more of a systematic approach to identifying studies to include, and we'll also be applying the barriers and facilitators to a theoretical framework that we can use to kind of understand implementation of pharmacogenomics in a little bit more depth. We've conducted a cross-sectional study where we've explored the use of antipsychotics that have got clinical dosing recommendations based on CYP2D6 genotype. We've looked at the use of these antipsychotics in an early intervention cohort that primarily supports people experiencing first episode psychosis, and we found that we found a high use of these antipsychotics, and without pharmacogenetic testing, we can't tailor the prescribing and the dosing of these antipsychotics to the individual. And then we're just in the process of obtaining ethical approval to conduct a qualitative study in which we're hoping to explore healthcare professional, carer, and service user perspectives towards using pharmacogenomics to support antipsychotic prescribing in early intervention cohorts. So that's kind of it from me. So in summary, today we've kind of explored what pharmacogenomics is, which is the study of how a patient's genome can influence their response to medicines. We've talked about how genomics is becoming a more mainstream part of clinical practice, and how pharmacogenetic testing, the availability of pharmacogenetic testing will increase in the coming years. I've been able to touch on a little bit about the implementation of pharmacogenomics in mental health and the potential benefit of that for patients, and what we might see in the future. And then just finally, we hope that we've kind of outlined how implementation of pharmacogenetic testing will require a very much multidisciplinary approach and engagement from pharmacy teams, including pharmacists and pharmacy technicians.